Well, a very warm welcome to all of those of you that are attending this most unusual RVC Virtual Open Day. I'd just like to introduce myself. My name is Michael Hewetson. I'm one of the senior lecturers here at the RVC. I'm a specialist in equine internal medicine. I work in the Equine Referral Hospital, but I also lecture the undergraduate students in Equine Medicine, particularly in the third year of the BVetMed course. I was asked to talk to you today about a subject that is related to my speciality, and I decided to talk about a common skin tumor in horses that probably many of you that know anything about horses may be familiar with, and this is the equine melanoma. What we know is that 80% of grey horses that are older than 12 years of age are likely to develop melanomas. And this increased incidence of melanomas in grey horses has been linked to the greying process that these horses undergo at approximately 5 to 8 years of age, when they start to gradually lose follicular pigmentation while maintaining a dark skin. So when you look at the skin of these grey horses, it's very dark, despite the fact that the hairs themselves are grey to white. This greying process we know is an autosomal dominant trait that's unfortunately also been associated with an increased risk of melanoma. And recent work has identified a genetic basis for this premature greying and identified a single gene mutation in the syntax 17 gene, also known as the STX17 gene. Probably what has happened is this gene mutation has been bred into horses in ancient times already, as we know that the grey horse has always been venerated by ancient cultures, and presumably previous cultures have actively tried to breed this colour, resulting in a perpetuation of this mutation through the generations, to the point where we see it today as a cause of these melanomas. What we know is that the gene mutation results not only in premature greying of the horse, but also in malignant transformation of normal melanocytes in the skin. And as a result, by definition, the primary tumor for melanoma disease in the horse is always dermal, so it's always in the skin. But we do know that these tumors may then go on to become malignant and potentially metastasize to other parts of the body. What's important also to realize is that in the horse, melanoma, as I said, is associated with a gene mutation and is not thought to be related to excessive exposure to UV light, as is the case in humans. So what do we know about this tumor? We know that most of these melanomas begin as benign tumors, and we'll go through the clinical presentation in more detail a little bit later. But unfortunately, evidence suggests that up to 2/3 of these tumors will eventually become malignant, and in some cases may even metastasize if left untreated. Most horses, we know, do not die of metastatic disease. In fact, metastasis itself is quite rare. More likely, these horses are going to be affected by the consequences of the local tumors and their effect on normal function. And in particular, we think about melanomas around the horse's tail and perineal area that may, for example, affect the ability of the horse to pass feces, leading to colic and other complications, just as an example. One other point to note is that we do sometimes see melanomas in non-grey horses. This is quite rare, but if you do see a melanoma in a non-grey horse, it's often a very aggressive tumor, and I always say that if you do see a melanoma in a non-grey horse, be extra careful and extra wary about the behavior of that tumor, because, as I say, they can often be very aggressive. So how do these tumors present? Three forms have been described. The first is the melanocytoma. The second is the dermal melanoma, and the third is the one we don't want to see, which is the malignant melanoma. And I'll just take you through the presentation of each three of those very quickly. The first is the small benign melanocytoma seen in young horses. It's usually heavily pigmented, as we can see here, and it's a non-encapsulated cutaneous nodule. We usually see it on the legs, the neck, but sometimes on the trunk, as we can see in this case over here. The most commonly recognized form, however, is the dermal melanoma, and this is the classical form we see in the older horse that's undergone the graying process. Usually, as I say, up to 80% of horses over the age of 12 will have some form of dermal melanoma. And these are characterized by sort of brown to black cutaneous nodules. They can be multiple, also coalescing in some cases. We see them most commonly underneath the tail and sometimes also on the external genitalia. But in certain circumstances, we can see them in other parts of the body, particularly in the parotid region, and as well as the lips on the head, eyelids, and other regions on the head as well. The important thing to remember is you can potentially find these in anywhere on the horse's skin. Depending on the size and the number of these tumors, they can often be complicated by infection and ulceration. And as we can see from this image here, here's a horse with multiple nodular dermal melanomas on the penis. Here's a classic presentation where we can see these melanomas around the anus in this horse. And then, as I mentioned, sometimes we see them in other parts of the body, in this case, in the parotid region. The worst of the worst, unfortunately, is the malignant melanoma. And as I say, we don't see this very often, but when we do see it, it is often associated with significant morbidity and mortality in the horse. Most horses will have dermal melanomas for many years before succumbing to metastatic disease. And as I say, in most cases, horses will die of old age before we see true metastatic malignant melanoma. But unfortunately, it does occur, and often one of the warning signs is that the melanoma lesions will be a more gray to pinkish heterogeneous color rather than the classical black or brown pigmentation that we see in the dermal melanoma. And this is always a warning sign. When they do metastasize, they tend to metastasize via the lymphatics and hematogonously, and we will see tumors, secondary tumors developing in sites like the lymph nodes, the liver, the spleen, and sometimes other organs, including the lungs and sometimes even the heart and brain. These horses will present with clinical signs associated with their organ affected, so they may present with things like colic, weight loss, and sometimes other signs like neurological disease. Here's just an image or a post-mortem of a horse with severe malignant melanoma, which is metastasized to the thorax, and this is the pleural surface of the diaphragm. We can see this very heterogeneous appearance to these tumors, with some of them being a sort of creamy color and not the classical dark brown to black pigment. This is an ultrasound of a horse's spleen, where we can also see these clear lesions within the spleen. This horse, unfortunately, had also developed a malignant melanoma that had metastasized to the spleen and other organs. When we assess a horse with melanomas, we often grade them to get an idea of severity. As we can see here, they can be graded from a 0 all the way through to 5, whereas a 0 is a horse without melanomas, and a 5 being a horse with severe tumor growth, often with infected ulcerative surface and a suspicion or evidence of metastasis to organs. And these horses often have, as I said, other clinical signs associated with these tumors, including things like weight loss and other disorders. Most horses we will usually be called out to see will it be in the early stages of a grade 1 and grade 2, where they have small single or multiple nodules that vary in size from 0.5 centimeters up to about 2 centimeters. But of course, these do grow over time, and we'll talk about how we deal with that in a minute. So the diagnosis is actually very simple. You can make a diagnosis in most cases on clinical presentation. So you have these black-brown nodules, as we've described. If you want to confirm the diagnosis, you can do a fine needle aspirate or even a biopsy. And as you can see here, you will have this obvious black pigmented tissue. We can see this in a cut surface from a horse that had a tail amputation, just to give you an example of the nature of how this tumor looks visually. If we do send a sample away for histopathology, the pathologist will report a fairly classical histological presentation of these tumors. The important thing to remember here, however, is that unfortunately the histological characteristics are not predictive of malignancy. And this makes things difficult for us because our biopsy is not necessarily going to tell us whether or not a horse is more likely to develop malignancy and potentially metastases over and above a horse that just has a simple, uncomplicated dermal melanoma. And so often we have to rely on other things like our clinical examination and other diagnostics to stage these tumors in more detail. With regards to treatment, as I said to you earlier, most melanomas initially anyway are benign, slow growing, and they tend to be space occupying without systemic implications, and as I say, in the classical sites around the tail and potentially the external genitalia of male horses. But as we know, up to 2/3 of these melanomas will eventually become malignant if left untreated, and as a result, it's important when we're giving advice to owners to make them aware of the fact that even though a horse might just have a small, fairly innocuous looking tumor, it's important that they don't ignore this and assume that the horse is going to have a good prognosis, because these benign small tumors will likely progress with time. And as a result, our feeling as veterinarians is that we should treat these lesions earlier when it's easier to treat them rather than wait until they become troublesome and cause further problems for the horse. And this is really a paradigm shift in our attitude towards these tumors. In the past, vets would always say to owners with grey horses that had melanomas, just keep an eye on them. They're almost a normal variant of the grey horse, and we'll just keep an eye on these. But nowadays we feel early intervention is the better way to go. So how do we treat them? Surgical excision with or without the use of a laser is probably the most ideal way to treat these tumors, because we can remove them in situ, and of course it's curative. If they are very large and infiltrative, and you're not able to remove them completely surgically, we can also perform partial excision, what we call debulking of the tumor. And the good thing about this is it doesn't necessarily increase the risk that these tumors will then become more aggressive or develop into malignant transformation. And often we would then use a combination of surgery together with other treatment modalities to try and reduce the size of the tumor. So here's just an example of a large tumor around the perianal region of this horse. We can see we've removed, or in the process of removing this tumor using sharp dissection, and we also used the laser to help us here. You can see this tumor has been lasered out. And this ended up as a very good outcome. We can see the anus of the horse here. It's had function, was able to pass feces normally, and we were able to remove this tumor completely. Sometimes, as I said, surgical excision is either not possible or we can't remove the entire tumor. In that case, we will combine it with intratumoral chemotherapy, and this involves injecting a variety of different chemotherapeutic agents into the actual tumor itself. These cytotoxic drugs are then used to help reduce the size of the tumor. We can do this by injecting them directly, or often we will mix them with something like sesame seed oil or use drug-impregnated beads in order to delay systemic absorption and increase the concentration of the drug at the site where we are interested in it working. More recently, we've also used a thing called electrochemotherapy, where we actually inject this drug into the tumor and then pass electrical current through the tumor. This electrical current increases the concentration of the drug within the cells, within the tumor cells, many-fold over and above what you'd be able to achieve without electrochemotherapy, and this increases the efficacy of the treatment. Unfortunately, we don't have a lot of data in melanomas. It's used very commonly in another type of tumor we see in horses, which is the sarcoid, but certainly it's something we are using more commonly in melanomas as well. We could also potentially try systemic therapy. There's a DNA-based vaccine called the Oncept vaccine, which is used in humans as well as in dogs. Essentially, it's a xenogenic tyrannase vaccine, which is manufactured or developed using DNA bacterial plasmid technology. This vaccine targets tumor-specific tyrannase, which is a protein that's overexpressed in melanocytic tumors. And by targeting this protein, of course, the idea is that we reduce the expression of tyrannase and as a result reduce the growth of the tumor. The current recommended dose is a vaccine every 2 weeks for a total of 4 doses, and then another booster at 6 months. Unfortunately, in the horse, there doesn't seem to be a lot of data out there that suggests that this is particularly effective. Most of it is very anecdotal, where veterinarians have reported shrinkage of tumors. But I think jury's still out with this treatment, and currently we don't recommend it as a sole treatment because there is no good evidence that it is completely effective. Lastly, there are reports of the use of cimetidine, which is an H2 antagonist, a histamine antagonist, receptor antagonist. The way this works is that it inhibits the immunosuppressive action of T lymphocytes, regulatory T lymphocytes. These lymphocytes, of course, are responsible for inhibiting the normal immune response against the tumor cells. And by inhibiting the T lymphocytes, we increase the likelihood of the body's immune system targeting those tumor cells and removing them from the body. There are some small reports with small numbers of horses reporting tumor shrinkage at doses of between 1.6 and 7.5 milligrams per kilogram daily. But as I say, the evidence is not particularly good, and it's limited to small numbers of horses. What we do know, though, is in humans, oncologists are using cimetidine quite effectively, but at massively increased doses over and above that which is used for the classical use of cimetidine, which is as an suppression of gastric acidity. And if we look at the comparable dose in the horse, if we were to use it at these sort of doses, we're looking at doses of 48 up to 72 milligrams per kilogram per day, which is massively increased over the dose which is currently being reported for the horse. So it may be that this still has some role to play, but at much higher doses than we are currently using. So in summary, this tumor is associated with a reasonably good prognosis for life, so long as we prevent these tumors reaching a size where they start to cause complications. And so appropriate regular veterinary care is really important. We encourage clients to monitor grey horses at least every 12 months and monitor the number as well as the size of the melanomas. Any melanoma which is a grade 1 or grade 2, we recommend removing these masses surgically once yearly, and any grades 3 up to 5, we recommend using surgical excision with potentially the use of other modalities such as the intratumoral chemotherapy I mentioned, or potentially other systemic treatments such as the vaccine or the cimetidine. So on that note, a very short overview of equine melanomas. Watch the space, and I encourage you to apply to come join us here at the RVC. And if you do, it's quite likely I may be giving you this lecture in far more detail in the years to come, and you might even get an opportunity to see these cases in reality in the hospital. And ultimately, if you manage to graduate here one day as a vet, you will be the one out there recommending these treatments for a client's horse. Thank you very much.